ultra-high risk patients with multiple myeloma.
Thank you very much. Thank you very much for the organizers for the kind invitation. It's of course fantastic to speak in front of such an audience, although scary after such excellent previous talkers. So I'm focusing on ultra-high-risk myeloma in clinical practice. In 2026, I think many of us are familiar that we have a problem at the moment if we use a one-size-fits-all treatment. And that problem may have slightly diminished over time, but it has certainly not completely disappeared. We do have a subgroup of patients that unfortunately encounters an early relapse. It might not necessarily be within 2 years anymore, it might be within 3 years, but actually it's still in the context of what we're expecting today far too early. And this is a little bit older analysis on the right-hand side, looking at the subsequent overall survival of these patients that encounter an early relapse, and it's unfortunately very short overall survival for these patients compared to those that are not having an early relapse. So the problem about that is, of course, if we focus all of our efforts on treatment optimization in the second line, that is the moment when it has already happened, and that is always a situation that is harder to rescue. Then the alternative aim, which would be stratified care. So in a stratified care situation, we would have better diagnostic stratification, hopefully a better patient outcome, probably also better quality of life for patients, because we could actually not only intensify for those that are in more need of treatment, but also potentially de-intensify more easily for those that have absence of these factors. And something that our healthcare systems, I think, are starting to understand, we also can provide a better value for the healthcare system. So the aim should really be to diagnose ultra-high risk early and treat differently in first line. So the challenges and aims of doing that, well, I think one of the challenge comes across as something that's actually positive at the moment. The positive side is that we nearly see a universal response now in newly diagnosed disease. So the problem is being shifted onto early relapse rather than primary refractoriness. We have to keep in mind, though, and I'll show you some data that is maybe looking a little bit historical, but I think it's something to always keep in mind. Early relapse is a one-size-fits-all treatment problem. The less treatment you give, the more early relapse you find. The more early relapse, and the harder the subsequent treatments are. So what do I mean by that? We looked at this systematically in the Myeloma 11 trial, where we had actually a large group of patients that had very uniform genetic profiling that was very, very close already to the updated IMS-IMWG classification, and that it included the gain of 1q, deletion 1p profiling, as well as all translocations. And then we looked at the randomization that happened in the trial after transplant. So half of the patients in the transplant got randomized to lenalidomide maintenance. The other half was just observed. Shows you the age of the trial, of course. It established later that it was very beneficial to have lenalidomide maintenance. But we did this subgroup analysis looking at just the single-hit aberrations and how much these patients benefited from just the addition of lenalidomide. And you can see on the left-hand side the T414 group that you would currently, as you can see on the bottom, not count as high risk anymore as per IMWG. They unfortunately have 60% early relapse rate if you don't give them lenalidomide. And that changes dramatically if you give them lenalidomide. The outcome is transformed. You can see the long time scale on the x-axis. You can also see the same for deletion 1p. It's not counted as a high-risk marker anymore, but that has emerged because we are treating nearly everyone now with lenalidomide maintenance. So it is not to be mistaken that this factor alone would not confer a bad diagnosis, and in this case 100% early relapse rate if we didn't treat these patients adequately. On the right-hand side you see deletion 17p, which is of course also now a high-risk factor on its own, but one thing certainly not to ignore the presence even of single markers entirely. And what is the other reason why we want to be sure that we treat patients with high risk and especially ultra-high risk disease appropriately in first line? This is another analysis that we did in the Mieloma 11 trial, a rather large analysis of 178 patients who donated in the trial not only the baseline genetics, but they also gave a bone marrow at relapse. And we looked at the common cytogenetic markers, so again, the ones that are now forming part of the updated classification. And we saw that from presentation to relapse, there was an absolute decrease in the patients with just no or one high-risk marker, and an increase in double and triple hit patients. These are normally tumors that are far more difficult to treat and far more resistant to treatment. So preventing early relapse prevents early disease evolution, and you can see on the right-hand side the subgroup of T414. There were just about 15% of patients that acquired deletion 17p at relapse, making them a really very ultra-high-risk group just by the nature of these patients relapsing. So it's really something that we need to keep in mind, to not treat a relapse as not something that is worthwhile in itself to prevent. So if we want to prevent the early relapse, we actually mostly face a diagnostic challenge. The less diagnostics we do, the more unexpected early relapses we have. We have, of course, now made a really fantastic leap forward with the new IMS-IMWG risk definition. I'm showing it in a slightly different way, and there's actually two reasons why I'm showing it in a slightly different way. I think it's worthwhile for us to keep in mind, on the left-hand side are all the lesions that our labs are really testing to conform with the calling of these abnormalities. But actually, the majority of the patients that we do call in the new classification are those with two or more of these high-risk cytogenetic abnormalities, and I'll show you the evidence in a second for that. That also happens to be a group that has been very, very widely validated as probably the most dramatically associated with an abnormal or unfavorable prognosis in several large meta-analyses. Of course, we now count the patients with the biallelic deletion 1p into this as well, but these are only about 1% of patients. And then there are the patients that have a deletion 17p on its own. These are a little bit more patients, but also those with TP53 mutations. Again, in a real-world analysis that we're hoping to present later in the year, these are the ones with just a mutation on their own are probably only about 1% of patients. So this is the evidence out of a real-world genetic testing review that we have done. If you only take the cytogenetic abnormalities into account, about 80 to 90% of the new classification actually carry two or more high-risk markers. On the very right-hand side, however, what one needs to keep in mind, if one takes beta to M into account as well, there is quite a lot of more patients that we call as high risk, and many of them do not carry any high-risk cytogenetic abnormality, and I think that's something to still, on an ongoing basis, establish what the prognostic meaning is. The French group presented some data in a recent blood publication where the prognostic impact was not as dramatic as the one conveyed by the cytogenetic abnormalities. So is our job done then in terms of identifying those patients that are at risk of early relapse? I think we unfortunately have to constitute that we still have a diagnostic gap, and the evidence is coming from several sides. With just doing the genetic testing with the IMS-IMWG definition alone, we still have 40% unexpected early relapses that are often also called functional high risk. Now, where is that evidence coming from? And this is a systematic analysis that we again did in the Mieloma 11 trial. We focused in on patients here that had a complete molecular profile, both RNA profiling and DNA profiling, and they all received a transplant and then lenalidomide maintenance therapy. And of those patients, 135 patients, 25 encountered an early relapse despite being on len maintenance. Now, if we look genetically, and genetics is of course something that looks at DNA mostly, we still identified only 15 of these 25. So 40% of the early relapses we would have in the clinic said had we only had this diagnostic tool were unexpected. But if we added RNA profiling, gene expression profiling, we were able to identify another 6 patients, and that reduced the number of unexplained early relapses to less than 20%. To be fair, even the other patients still often had other lesions too. Interestingly, had a T1114 translocation, which might have to do with the data that you have seen earlier already about the real response of these groups. So it sounds for many maybe as a distant science fiction to do RNA profiling. However, those of you who are treating ALL or who are maybe treating breast cancer know that actually RNA profiling has found its way into very much standard diagnostics in many diseases. Our labs all have pipelines to extract DNA and RNA in parallel, and actually as a molecular test, it pretty much fits into modern high throughput genomic analysis pipelines. So actually there is a CE accredited diagnostic test for gene expression risk profiling, the Profiler test, and I think we should really it should click in our brain that other diseases are doing this quite regularly. On the right-hand side, you can see why the information is non-overlapping. It's actually pretty similar in breast cancer as well. When you look at the DNA, you look, of course, mostly at historical damage of the genome that has already happened. It's a sign of that the disease is evolved and has more resistance to treatment, but it's past damage. And the RNA side, of course, shows the present state of the cell. It shows particularly an enrichment of proliferative genes and whether the tumor is growing fast. It's probably the closest what we have to a Ki67, which many of you will use on a daily basis on the lymphoma side. So that paints the picture then that if we do comprehensive baseline risk profiling, we can probably design a better long-term care pathway for our patients. Because if you look on the left-hand side, still having 40% unexplained early relapses are just too many to do consistent decision-making based on our baseline profiling. If we combine genetics with transcriptional profiling and probably also imaging, which the role of which is increasing, especially with immunotherapies and the importance of extramedullary disease, we stand a very good chance of reducing the number of unexplained early relapses to less than 20%. And that is, of course, a diagnostic confidence with which we then can operate to personalized care much better than before. And it probably is not by pure coincidence that for that reason, transcriptional profiling, the myeloma gene test is at the moment under review by the healthcare payer in the UK. UK NICE has opened a formal cost-effectiveness assessment of the RNA test, and there is actually an implementation of this test now in a diagnostic pathway that we have rolled out at our institution called MyTrack for anyone who is interested. Just putting this into a search machine with our hospital's name gives you more information. So nevertheless, coming back to the question, what do these genetic factors have to do with outcome of the patients that are sitting in front of me? We need to survey the problem with the current one-size-fits-all treatment, particularly for those patients for which we have most published information, which are the ones with the 2 or more high-risk cytogenetic abnormalities. And there's, of course, very interesting data now out from trials that have long-term follow-up, because that's what we need to really understand what the prognostic impact of these lesions are. The Griffin trial, it was the predecessor trial to the Perseus protocol. As you can see on the left-hand side, when the trial was first presented with 2-year follow-up, the progression-free survival looked as near 100% for all patients. So actually there was a notion at the time that the disease was effectively cured. However, in the 4-year and longer follow-up of the Griffin trial, where a genetic subgroup analysis was performed, where the counting of high-risk cytogenetic abnormalities was included, you can see that those with 0 high-risk cytogenetic abnormalities had a PFS of nearly 90% still after 4 years, whereas the median PFS for those with double hit was 36 months only. And I would like you to memorize this number because it will actually repeatedly come back in the remainder of the talk. One of the examples where it comes back is already on the next slide, on the master trial, which is an induction regimen with DARA-KRD, probably the most potent that we can give if you have access to this regimen. Even gave more consolidation therapy than many of the standard regimens at the moment, with very high MRD negativity rates, again split up by the number of cytogenetic abnormalities on the left-hand side in a small diagram. But then interestingly, with a 4 years and longer PFS follow-up, again, the median progression-free survival for the double hit group is 36 months. And again, actually an excellent outcome for those without cytogenetic abnormalities, which I think is a huge achievement with what we're doing at the moment, because these are 50% of our patients, but the double hit patients, 36 months. And actually quite a similar experience that has now been reported by the IFM in their validation of the updated IMS-IMWG score, just published in Blood, and this has been kindly shared by Gilles Corre. You can see here all the blue bars are actually the cytogenetic abnormalities that are a single hit that are happening, and the median progression-free survival mostly lying above 30 months. And then the yellow bars are the patients that carry a double hit disease, so 2 or more high-risk cytogenetic abnormalities, and nearly throughout these patients have a progression-free survival of less than 30 months. That, of course, brings the question, well, if so many trials have shown all of these unfortunate outcomes, do we even stand a chance of improving the outcome for these patients? And I want to say yes already, but I wanted to convince you with data. So what would be the idea? And the idea has been there for a long time, of course, but it was tested a while ago in order for us now to have mature data. And the idea is that the problem really shifted several years ago with the introduction of quadruplets to an early relapse problem, then a primary refractoriness problem, which then poses the question, in our standard treatments, we're dropping the intensity after the consolidation quite a lot. Would maintaining intensity actually be tolerable and lead to better outcomes for our patients, or would we just ruin their subsequent chances of a relapse to anything because they will be immediately refractory to combination maintenance treatment? And these were the 3 trials that prospectively aimed and set out to answer this question. The Optimum trial on the top, starting with a quad with cyclophosphamide, single transplant, then 18 months of a quad and a doublet maintenance therapy until progression or a lack of tolerability. The GMLG concept trial, pretty similar, with even a more intensified triplet maintenance therapy with carfilzomib as the combination partner. And at the bottom, the IMF trial that I will not go into more detail. You have seen some results of the doublet transplant that actually form part of this trial as the only one of these 3 high-risk dedicated trials. I think what is important to keep in mind when looking at the results is none of these trials had a screening period in the classical sense. They were really designed to capture every patient that comes through the door and has very unfortunate disease. They all allowed a pre-treatment with a standard of care regimen before the cytogenetic test result was back. And I think it's important to keep in mind that in many industry trials, these patients will have been excluded during a screening period already. So this is the trial that I've been most involved in, the Optimum Mark9 trial. It was an all-comer study, actually, and the patients were identified through a central genetic and gene expression screening, a combined testing. It also made use of the same information being available from a previous trial, the Mieloma 11 trial, and the same tests were used in that. So it's, again, important to reflect in this trial, ultimately, if you take both populations together, 913 patients were centrally screened for genetics and gene expression, and 227 ultra-high-risk patients were studied in the study. That is just as a context compared to 154 in Perseus. So the treatment I've already gone into, I'm not going to go into much more on that. The external comparator arm had pretty much a triplet induction transplant and then maintenance therapy. And this is the overall result for all patient groups together, which shows a really dramatic uplift of the progression-free survival now with 6 years of follow-up nearly. Interestingly, the black curve in the middle is patients treated with KRD, transplant, and LEN, and it has exactly the 36 months of PFS that you've seen in other trials before. So we do have quite a good notion that what we have changed in this trial is the extended consolidation therapy, and this probably gave the biggest impact on this uplift in progression-free survival. But what we didn't quite anticipate is that after 6 years, patients are still benefiting from the treatment whilst being on doublet maintenance therapy. So all of these patients that are on the trial still have now had more than 5 years of ongoing doublet maintenance treatment. And this was, of course, the biggest question for us. Are we just deteriorating the subsequent treatments and making patients' overall survival shorter through that? And we did not. We did extend the overall survival through our intervention. We calculated the number up just assuming numbers of patients diagnosed with high-risk disease or ultra-high-risk disease and myeloma every year in the UK. And if we compared it to the other treatments that we gave in the trial over a 5-year period, we would have saved 114 life years through given the risk-adapted treatment. So that is, of course, an achievement I think that we have not seen before. But the data now allows, of course, a deeper dive as well, because we did the RNA and the DNA-based profiling. So who benefits from the treatment, really? There were probably 2 or 3 groups, depending on how you look at it. So one group was the double-hit patients. These are patients that many of you will already be able to analyze in your current practices. But the additional information that we had, whether they had gene expression high risk or not, but nevertheless, as such, you can identify that group. And then there was the group of 10% of patients that we would miss at the moment in the clinic because they were only identified by gene expression high risk. Coming to the first group, the ones that many of you would see in clinics, they have very clearly benefited as the double hit group, and the median progression-free survival has not been reached. But the one that was really interesting us, of course, was the gene expression high-risk group, because we wanted to know, did they really do badly in the other trial, and did they do better in the new trial? And yes, they are unfortunately doing badly if we don't treat them correctly. And the bigger problem is if we don't identify them, we don't even know whether we can treat them correctly. So we can treat gene expression high risk definitely better if we diagnose it. The median progression-free survival, again, not reached, 5-year PFS is 62%. What was probably the even bigger surprise is if we split the group of double hits into those without gene expression high risk, we get an excellent result. We get a 48 months progression-free survival of 91%. And again, for context, the all-comers, so standard and high-risk progression-free survival in Perseus is 84% at 48 months. The group that, however, sticks out more on the other end as being still an unmet need group is the one that has the double hit plus the gene expression high risk. The median progression-free survival is reached here at about 4 to 5 years. And clearly, the group did even worse with the treatment that we gave them before, so they're clearly benefiting from the therapy, but not as much as we would like to. Now, one group that has very, very clearly emerged from this analysis as a high unmet need group is the group of patients with triple hit disease. So we can see here we're splitting the results up by having no hit, but gene expression high risk, having 1 hit. Again, they found their way into the trial through the gene expression criteria. We have those with 2 hits. All of them actually have not reached their median progression-free survival, but those that have 3 cytogenetic abnormalities, unfortunately, have a dismal outcome, both with the new and the old treatment, and this is a group we should definitely focus on in prospective high-risk trials. And the other group that remains a challenge in our analysis is the plasma cell leukemia group. Having said that, all previous trials that are reported did include some or the other element of allogeneic transplant, so I think this is at least a clear picture of the outcome that you get with modern quadruplet and just a single transplant in that group, which probably will still form a very valuable comparator for future analyses. Interestingly, all of these patients have gene expression high-risk disease. Very few patients, or the minority, has double hit, and no one has triple hit disease from these patients. So it's probably a biological factor that drives the outcome that we are not understanding entirely, might be linked to the T1140. Very reassuringly, the GMGG concept trial is showing pretty similar results with the DARA-KRD regimen. Here it is again the long-term follow-up of the sub-cohort, the safety run-in of transplant-eligible patients. And what's interesting as well from data that Lisa Leipold presented at last year's meetings, that there is also this pattern emerging of those patients with co-occurrence of high-risk lesions, and probably also some patients in there with triple-hit disease having a dismal outcome. So you might ask now, okay, he's shown me all of this data, how on earth am I meant to be translating into my standard care? And I just want to highlight this bit of it. If we look at what many of us now have approved in our legislations, Optimum Mach9 is not such a huge uplift, and the only drugs that need to be added to the regimen are either off-patent, bortezomib for 16 cycles, or it is a continuation of the treatment that we are, as per the license, meant to be doing in, for example, the MRD positive anyway, which is continuation of DARA-LEN maintenance. So you could call this regimen potentially a Perseus Plus. The problem is there will be no pharma company that will bring it to your payer. This is down to us. This is down to your professional societies. This is down to us locally to make the advocacy that this relatively low-cost addition to the treatment is really implemented. I'll come to my penultimate slide nearly. This is the derived algorithm that we are thinking of at the moment as a proposal from the information. I start on the very right-hand side. Those patients with triple hit disease or double hit and gene expression high risk, as well as the plasma cell leukemia patients, We are seeing certainly some uplift for some of them, but I would primarily think we should consider these patients for our new high-risk trials that we're designing. The double-hit patients that really only have 2 high-risk markers, but no gene expression high risk, or those with just gene expression high risk, have an excellent outcome with optimum MAC9 treatment, so the prolonged consolidation therapy. I think there's also an emerging evidence, of course, of data that was just shown at ASCO that the single-hit patients, they really benefit from the Perseus type treatment as well as the 0-hit patients. But it will be an interesting question whether the patients that really have complete absence of all of these markers may actually really benefit from stopping as per the master trial results that we've already seen. And that is something that we're focusing on, again, in our new diagnostic pathway called MyTrack. In summary, diagnostics I would consider as the essential part of managing ultra-high risk. We cannot think about the treatment without thinking about the diagnostics. The updated guidelines are helping us a lot. I think the gene expression profiling might head our way more than we think at the moment, but we need more advocacy for broader access. Risk-adapted treatment in first-line markedly extends progression-free and overall survival for data that we are expecting to see coming out in Lancet Oncology over the coming weeks. From the Optimum MAC9 6-year follow-up, but for all of us to access this treatment, because it's in a result of an academic trial, it will need advocacy with our local communities. And one thing, of course, that many of you will see later in this meeting, and we're all looking forward to the fantastic abstract that is announced for Saturday for the updated subgroup analysis from the TEC3 trial. We will probably have to redefine our ultra-high-risk definition with T-cell redirecting therapy, but we're all curious what the results will be. These are all the acknowledgements of all the parties that have participated, and thank you very much for your attention.